my name is Jen Carlquist, and I am a physician assistant. I work in cardiology, and today we're going to talk about the atrial fibrillation toolbox. We see a lot of AFib in the clinic, and the biggest decision we have to make is, are they at risk for stroke? So the first thing I think when I see an AFib patient walk in the door is, do they need an anticoagulant? So we do a risk stratification, including a CHAD score. There's a lot of different scoring systems and a lot of controversy about them, but basically CHAD's 2 score is what we're using these days, and if their CHAD's 2 score is 1 and below, you can get away with using just aspirin. Okay, so 0 to 1, aspirin. Now, once they get higher on that score, then you've got to decide whether to put them on, so basically 2 and over, and you can honestly make a case for 1 and over if you want to be really careful. You have to decide what anticoagulant to put them on. So the next question you need to ask yourself is, do they have valvular disease? So if they have valvular AFib, you can't use a novel. You have to use Coumadin or warfarin. But if you don't, then you can actually offer the patients both choices. So there's a long list of things you need to consider. So first thing is money, right? So if cost is an issue, patients are going to choose Coumadin. However, there's no free lunch, so they have to factor in coming in and getting their finger poked. So there's a lot of time, right? There's a lot of time involved in being on anticoagulation. But if they have the money and they don't want to come in for routine finger checks, and if they don't want to be careful with diet and avoiding leafy greens, then they can technically all go on a novel anticoagulant. Now, they're all pretty expensive. There's a lot of them that are basically the same efficacy, except for there is one novel anticoagulant that stands out from the rest as far as lower bleeding risk and better stroke protection, and that's Eliquis. So Eliquis is my #1 choice for the novel anticoagulants. However, the next question becomes, is there a reversal agent? So there's just been released for Pradaxa a reversal agent. So that makes Pradaxa a little bit more attractive. It's been out a long time, but we do tend to find a little bit more GI bleeding with Pradaxa. But our kind of go-to motto is, if patients have been on it for a while and they've been tolerating it with no GI bleeds, then we kind of don't fix it if it's not broken. We leave them on it. So you got Pradaxa, you've got Eliquis, you've also got Xarelto, which is also great. Now, these need renal dosing, which is something to consider. And you've got to factor in, of course, whenever you're talking about blood thinners, you always have to factor in fall risk. So are they high risk to fall? Then that sometimes will outweigh the need to put them on anticoagulation. But whenever I have a patient who has AFib and they're at risk for stroke, I'm always going to document why they're not on a blood thinner. So maybe they just had a recent GI bleed, or discuss with family and patient and supervising physician, and patient is too high risk to fall, so the risks outweigh the benefits of putting them on the medication. That way, if they do down the line have some sort of bad outcome, you've documented your decision making. And I especially like to include getting the family involved, because that way they're not surprised. They are very educated and they can make informed decisions. So the next thing you have to decide is rate control. Now, there's a lot of options. You can use a calcium channel blocker, you can use a beta blocker, or you can use Digoxin. So calcium channel blockers are great, but they do lead to constipation. Some of them can lead to increased lower extremity edema. Beta blockers, obviously you have the whole respiratory situation to worry about, so if they're asthmatic, right, you may want to avoid it. Digoxin is a great go-to. People don't like Dig, and Dig has a long history of being hated. But the thing is with Dig is it's a kind of a nice go-to when you have a patient with heart failure and they have AFib and their blood pressure is low and you really need a little bit more rate control. Dig is a kind of good go-to med for that, and it's cheap. So we like Dig because it's cheap, but you have to measure the levels. So there's a narrow therapeutic window, so that's something to think about. But again, with any medication, there's no free lunch. Then you've got to decide the strategy, right? So your strategy is either going to be, I'm going to control rate, or I'm going to control rhythm. But there's a third strategy. And the third strategy is I'm going to get them out of AFib altogether. So if you want to decide that I'm going to get them out of AFib altogether strategy, so for example, a patient fails all their meds, they don't want to be on blood thinners anymore, then you can sometimes get away with doing an ablation, a cryoablation. Now, in order to be a candidate for ablation, you have to not have sleep apnea, or if you do, it has to be treated. You have to have a good look at your atrium, because the large atriums don't hold an ablation very well. So you need an echo. And you also need to make sure your AFib is not an ischemic substrate. So they need to have a stress test to make sure their AFib is not being caused by ischemia, so a blocked coronary artery. So they need a stress test, they need an echo, they need a Holter most likely to assess rate control, and that's also going to help us document if they're paroxysmal atrial fibrillation, so if it comes and goes, or if they're persistent or chronic AFib. And then we also get an idea of what their rate control is over a longer span, which is helpful for the medications, so we know how to adjust them better. So let's say you've decided that you want to get them out of AFib altogether and not even go through any of this hassle. Well, the one thing patients have to know is that they're going to be on blood thinners for at least 3 months after their ablation, so they have to be on it before and after. At least a month before to prevent clot, and then 3 months after, because the heart kind of goes wonky after an ablation and you can have extra ectopy or additional AFib, so you need to cover that patient. And then usually we'll need to get a Holter monitor to decide if they're completely out of it before we decide if we're going to take them off their blood thinners. So it's a very long process, but it's worth it for those patients who can get off the meds. Now, the other thing you need to decide is, do they have heart failure? So again, that's where your echo is going to come into play, because you're going to get to see if your ejection fraction is under 35. Now with ejection fraction, 35 is sort of a magic number, and that's one of the things that we kind of hang our hat on and we're always looking at is, what is the EF? If the EF is lower than 35, the patient's going to be a candidate for a defibrillator. Now wait a second. What if it's 35 just for today? Or what if it's 35 because they just recently had an MI and they had cardiac stunning? That's why we actually have to wait before we put a defibrillator in. We have to see if the heart's going to heal. So usually we need another echo. If it's post-MI, like 40 days, or if it's non-ischemic cardiomyopathy, we need to wait 90 days. And then if their EF is still low, then they need a defibrillator. Well, that leaves the question of, what do we do in the meantime with a patient who has an ejection fraction that's lower than 35, but we can't put a defibrillator in them? What do we do with them? Because we know patients with low EF, especially under 35, are at high risk for ventricular arrhythmias, like VTAC, like VFib. So are we just going to leave them walking around unprotected? And the answer is no. There's another device we can actually use. It's called the Life Vest. And the Life Vest is a wearable external defibrillator that actually can protect the patient from cardiac arrest 24 hours a day. And it's sort of like the best success rates out there for cardiac arrest. If I ever have cardiac arrest, I want to be wearing a vest. I used to think being at a casino was the best place to be, status post cardiac arrest, because they have the defibrillators that come to you, they have the trained people to do CPR, they have cameras on you at all times. But actually, hands down, I would pick the vest because it shocks you immediately if you have an issue. So even in the hospital, sometimes we'll leave the vest on if they're a high-risk patient, because we know that by the time the code team's called, by the time everybody rallies up to get to the patient, the vest could already take care of the problem. So EF is a big deal for that, but it's also a big deal to decide if we're going to do the rhythm control, what meds we're going to choose. So if they have heart failure, and the answer is yes they do, then pretty much the only med that we can use is amiodarone. But amiodarone has a lot of good benefits because it has so many different things it can treat. It can treat AFib, it can treat VFib. Pretty much there isn't anything amiodarone can't treat, but again, no free lunch, because the amiodarone can mess with your thyroid, can mess with your lungs. You can get blue tinting of your sclera, which is not attractive, pulmonary fibrosis, hypothyroidism, not good things. But that's why we keep you on the shortest duration possible. But if you're 90 and something else is going to kill you first, amiodarone is a good go-to. If not, if the answer is no, then you have lots of choices. So you can use things like flecainide, if no heart failure. You can use rythmn, propafenone, and sotalol. So sotalol has to be started in the hospital. Sotalol can prolong your QT. Actually, any of these can. Amiodarone will prolong your QT up to 80 milliseconds, which can be a lot. But sotalol, surprisingly, even though it doesn't increase your QT as much, it has an increased rate of VT from torsade to pointe, which is from the prolonging of the QT. So that usually has to be started in the hospital, the sotalol. Whereas the other ones cannot. And sometimes, this is another little trick for afibbers, if we have people who are paroxysmal afibbers, or even people with SVT that's very rare, we'll sometimes do a pill in the pocket strategy, which is keeping a pill of your novel anticoagulant and your anti-arrhythmic drug in your pocket and starting it if you have an event. So we kind of get creative sometimes, and everything is always a cocktail. Sometimes you use both rate and rhythm control, but you have to kind of factor in a lot of things with AFib. And one of the biggest things I think that we need to think about as providers is, why do they have their AFib? And that's a big question we need to ask, because it's not enough to know that they have it. We need to know why. Again, we need to get a stress test. Is it an ischemic substrate? Do they have heart failure underlying? Do they have sleep apnea and it's not been treated, which led to heart failure, which led to AFib? And especially if we get a Holter monitor and somebody's had a bunch of AFib at night, that's when we'll think about sleep apnea pretty hard. We'll look hard and fast at that. And then we need to decide, is this stuff working? A lot of times, I forgot Multac. Is this stuff working? And if it's not working and they don't want to spend a bunch of money on their meds, then maybe we have to think about a different strategy where we just focus on rate control instead of rhythm control. And that's okay as long as they're not symptomatic. Because the decision we've made at that point is, they're persistent AFib, they can't have an ablation, so let's pick rate or rhythm. Rhythm didn't work, because the other thing is, some of these drugs can actually be pro-arrhythmic, so cause more problems. So there's a lot of things that go into thinking about AFib,